Ambulance Medical Necessity webinar. This webinar covers what ambulance transports Medicare will cover and why. I'm Tom Ryan with Provider Outreach and Education, and I'll be your presenter today. Today, I'm joined by Ashley from my team, who's going to help with those questions in the chat. She's going to add some additional resources and give you reminders and prompts in the chat to make sure that everything is working for you. I do want to provide one reminder to you guys as you get into this and you're really watching this. Many of you that are registered for the live event are not from a WPS jurisdiction, which is jurisdiction 5 or J5, Iowa, Kansas, Missouri, Nebraska, billing on a 1500 claim form or an 837P. Also would incorporate billing on a UB04 or 837I and add our national providers into that. So it's Iowa, Kansas, Missouri, Nebraska, and national providers. We also have jurisdiction 8, which is Indiana and Michigan, and that's anyone that bills for those. So some of you did indicate that you are not from our jurisdictions. You are welcome to attend this event and listen in on the information. A lot of the information I'm going to give is national information, but there will be some recommendations, and WPS will say, this is our advice, or we think this, or this is what we'd like you to do. So as I state that, remember that it may not be applicable to what your MAC would like to see. That is clarification or information coming just from WPS. You can contact your MAC for additional clarification, or you could also consider attending the September 16th, 2026 National AB MAC Ambulance Provider and Supplier Coalition meeting, which is currently open for registration and still taking questions. So I thought I would put those two options out there right away for you. All right, a little bit about what we're here today. Today, my goal is to avoid the medical necessity review findings for ambulance documentation and medical necessity. So what's happening is not only is WPS reviewing ambulance claims, but so is the CERT, the Comprehensive Error Rate Testing Contractor, the Recovery Audit Contractor, and other entities. And what they're finding is that a lot of the ambulance claims that are being billed are not medically necessary. So we do want to define the ambulance benefit. This makes sense. We're going to then explain the medical necessity criteria, and we're going to explore some documentation. Now, a couple people asked me how we're going to do all of this. The exploring the documentation will be more through scenario-driven questions, so a little bit more to think about with that. But we're going to talk about the benefit itself, which is some basic things, and then the EMT assessment, which is what proves medical necessity. We'll explain that criteria that goes with that, and then we do have some questions on the physician certification statement, so we will cover a little bit more information on that. All right, so what are we first going to start with? Well, let's define what Medicare uses for medical necessity for an ambulance transport and why that information is important, because it does make things slightly different than a lot of other medical necessity information. And I want to remind you of that because of the way the Social Security Act is written and where this comes from, it does make like even the use of an advanced beneficiary notice of non-coverage a little different and less often used for ambulance than for some of the other services that you may be aware of. Okay, so as we get into that, remember, we'll try to get through all of those different types of questions. The first thing we have to talk about when we're talking about medical necessity for ambulance is that CMS uses the definition from the Social Security Act, Section 1861 S7. So therefore, your documentation must support this. Well, how does that documentation support this? Well, what is this? Well, let's answer that. First, in that section, you can see there's a direct quote provided on this slide. Ambulance services where the use of other methods of transportation is contraindicated by the individual's condition, but only to the extent provided in regulations. It's a lot of words. So here's the thing, if you do not meet this definition, then that service is not medically necessary, but also that service is never covered, not covered, or non-covered, whichever term you want to use by Medicare. So that leads me to say, we better break this Social Security Act quote down a bit further to make sure you're hitting all the portions, because all three portions have to be met. So let's talk about the first portion, which says it's a transport benefit. That means you have to transport the patient. So the question came in, well, what happens if we don't transport the patient? Well, can you tell me why? Okay. Why didn't you transport that patient? Was it a treat, no transport? Meaning you arrived on scene, you treated them, but you didn't transport them. Well, then you're going to bill an A0998. That's the ambulance treat no transport code. But here's the thing, CMS recommends putting a GY modifier on there. Now, we're going to tell you at WPS for our system, put the GY on there. It's going to make it so much faster within our system. It actually bypasses a lot of the edits and says, oh, we're done. Okay. Now, if you do a treat no transport and you do provide an advanced beneficiary notice of non-coverage to the patient, just saying, hey, this isn't a covered service because we're not transporting you, you can put a different modifier on there, and that's the GX. So GYGX just depends on whether or not you gave an ABN. Okay. So when we look at this transport, one of the things to keep in mind too with transport is going to be contraindicated. We'll talk more about that next. But basically, the transportation has to occur means you literally have to load them in the ambulance and move them somewhere. There was asked about a deceased patient. We'll get more into that when we get into the question and answers, but I do want to recognize that there are times when the transport doesn't occur due to that, and that would be a payable service, but you have to bill it correctly. Okay. So when we look at transport, don't consider that another method is not available. So you transported the patient, but it's because it's 2 a.m. and there's no wheelchair van available. Well, that doesn't make it medically necessary. Yes, you transported them, and yes, that does work. One of my favorite examples given from the chat was, or I'm sorry, from the questions was that the patient doesn't want to disturb someone. Again, the example given was it was 2 a.m. and so they don't want to call. Well, that doesn't mean that they couldn't have gone by a different means. And yes, you transported them, but it's the patient's choice. So we do look at these different types of items to see whether or not the transport, one, occurred, and two, whether it was needed. Okay, let's go on to the next slide because the next slide talks about contraindicated. Now, from that Social Security definition, contraindicated means this is the only safe method of transport. This method of transport is a state certified ambulance transport, regardless of whether it's air, BLS, or ALS certified. So it is a requirement to be state certified for, or I'm sorry, state certified at the level of an ambulance. So that is what contraindicated means. Well, what does that mean in terms of overall? Well, let's talk a little bit about that. So when we talk about the only safe means of travel, it means that one, if the patient could have gone by any other vehicle, even if it's not available, that will not meet the definition of contraindicated, which means it's not part of the Medicare ambulance benefits in the Social Security Act. Okay, so there's where we come up with contraindicated. So when our particular reviewer at WPS is looking through the information, they're looking for why the EMT, the emergency medical technician, and it doesn't matter what level you're at, um, whether you're an EMT basic, intermediate, or mid-level, however your state defines that, or a paramedic, one of those types needs to have their medical training required or needed, even if it's just for monitoring. What makes them needed? Why are they here today? If they're not, then it's not contraindicated. Okay. And keep that in mind. It also goes a step further to say contraindicated by air means that they couldn't safely have gone by ground, which is still a medically necessary transport, but it's a little bit different when we look at that one in terms of getting billed. So, yes, it's still medically necessary to go by ground, but we took them by air. That gives an extra step into it. So when we look at that portion for contraindicated, what we're looking for is no ambulance, air, ground, anything is required. In other words, they could safely have gone even if that method isn't available. So hopefully all of that makes sense. One of the ones that we were asked about, and I'm going to use this term here, is There's a homeless person that wants to go to the ER due to the cold or due to whatever. Well, why does that homeless person need to go? Not want, but need to go. What skills are the EMT going to use during that transport? If it seriously is just a want to go and they're just wanting to avoid the cold or they're wanting to avoid whatever the situation is, and the emergency medical technician is loading them, taking them, that's probably from the description or from the question that was asked, not going to be a covered transport because it's not contraindicated. They could safely have been loaded into a public vehicle, even though they couldn't afford it. That's okay. They could safely have gone by that. They could safely have gone by a police. So that was just a really good example that I thought, hey, this was really nice. Okay. There was another one where there was a call that came in from the SNF. This is another question, sorry. A 911 call comes in from a skilled nursing facility, but there's no complaint given. The skilled nursing facility requests the patient to be transported. Okay, so when you get there, the EMT, the emergency medical technician, does an assessment. And we'll talk a lot about that assessment. And what we're looking for is I get that the SNF called, and I get that you may be required due to local regulations to transport this patient. However, without the EMT assessment stating why it's medically necessary, it may not be covered. So just because the SNF called 911, which is the skilled nursing facility, it doesn't automatically make it covered. Just because you have a local regulation, it does not override the Social Security Act. So there's a bunch of different things going into those two questions, which will all play into the EMT documentation that we're going to talk about in just a little while. All right. So that's contraindicated. Regulations. This is my favorite part because some people are like, well, I don't really understand what it means by other regulations. So I will let you know this is where we talk about all the other things that covers Medicare that are general regulations. So, for instance, Medicare secondary payer or MSP, we still have to consider that. So, does the patient have someone before Medicare who should be paying? That's when we become the secondary, right? So, MSP. So that is a consideration. The level of care being medically necessary. This is something else I just described. So was it emergent or non-emergent based on the dispatch and meeting the Medicare definition of that? Could the patient have gone safely by ground, but did go by air, making the ground transport medically necessary, but not the air? Well, did it get documented in general? There are some times when what we're getting back from you, the provider community, is that oops, we documented this, or oh, this documentation isn't there, something's not right with the documentation. Anything that is not correct with the documentation can cause an error. Okay. Also, just because the service is felt to be medically necessary and needed, there are covered destinations by Medicare. So if you're transporting to a non-covered destination and it's never going to meet one of the destination requirements, that service is not covered by Medicare. So let me give you an example. You are transporting to a physician's office for a physician's visit. Medicare states that this is a non covered destination. The only exception to that rule is if it was not the original destination, but you stopped due to patient condition and an emergency requiring it. So there are two different destination modifiers, a P and an X. So the destination would not be covered. Well, then that is not something you can bill to Medicare and expect for us to review and pay. It doesn't mean you can't bill it. You could bill it with a P as a destination modifier, and we'll automatically deny it. And the last one is transportation inside the US. If the transport starts outside the US, and we do occasionally have this happen, then it's just when they hit the border, how many miles can we pay? It's not the total miles. Also, we could pay for outside the US if that's the nearest hospital that could provide an emergency room. Not so much happening in jurisdiction 5, but jurisdiction 8, it can happen in. And we say that because what if the nearest ER from the Upper Peninsula is actually across the border in Canada? And that does happen. Therefore, the payable destination could be that, and we will consider that because of the patient's condition. So hopefully that all makes sense. But those are all the other like coverage criteria that go with different things. What I decided to do for this one on the regulations was to put the code of federal regulations in there for you. So if you notice, there's two links on the bottom of the slide, and they're way down here in the bottom, and they're going to give you those other types of regulations. We did have a few questions just specific on what we consider when we talk about air versus ground and what makes air transport covered um, versus just taking them safely by ground. The key question you want to ask yourself, if this patient could safely have gone by ground, will Medicare consider the air ambulance transport medically necessary? To do that, you need to analyze one, what is the total time for that air transport to occur? It's not just the actual flight time. So let's say that we're using fixed or rotary. So let's use fixed first. What is the time to make the dispatch for the fixed wing? Second, they're going to taxi and park at the airport. Now you've got to transport the patient to them, load, fly, unload, and transport the patient to a hospital. That's how a fixed works. So all of that time gets considered. Unlike some of the rotary, where you actually land at the hospital, they load them, and off they go. They land at the hospital and unload them, and off they go. Again, we're going to look at that. How long does it take for the rotary wing to arrive at the hospital so they can be loaded? So that's where time comes in. Hopefully that makes sense. Sometimes it's distance, but other times when we look at distance, it seems, oh, well, if we took them as the crow flies, it's okay, right? Except what's the problem? Well, on the UP of Michigan, can you always transport state across that? No. How about the western side of the state of Nebraska or Kansas? So when we look at that, we do have to consider distance, roads, closures, storms, all of those things to talk about air ambulance. Okay. So hopefully all of that makes sense. I kind of just really provided a general issue with air ambulance to answer the question. Um, but I will tell you that there's more. And if you want to learn more, please put some questions in the chat so that I can get you more information. I did try to provide just some general stuff. All right. One of the issues we're having directly relates to medical necessity for ambulance transports. And by we, this is WPS. This may not be applicable across the board. Here's what's happening. An ambulance supplier is billing with the modifier GY. Now, we've done specific education on this. There are YouTube Encore presentations available. The GY modifier on an ambulance claim means that it is not contraindicated for the patient to go by that means. So the EMT did the assessment. When the coder went to bill it, they're like, yeah, but I don't see where they could require the EMT. Maybe they could say if they have gone by a different means. So they bill it, meaning, hey, it's billed with the GY, and that is correct. Then what happens is someone from their staff is trying to be nice to the patient. And so they file an appeal on behalf of the patient, but are they filing it correctly? And the question that comes up with that is why? Well, one, if an ambulance provider suddenly feels like it is medically necessary, or someone within their staff reviews it and determines, wait, yep, this should have met medical necessity, you don't file an appeal, you file a corrected claim, or you do a clerical error reopening and remove the GY. If you're filing it on behalf of the patient, then you have to remember the patient has to sign and date it. And it has to be stating that they want the appeal. Now, you can physically send it with a copy of the run report, that's fine. But the patient must sign and date that appeal. If that doesn't happen, then you as a party are considered the filing entity, and we would uphold it, or we would dismiss your appeal because you billed it that way. So hopefully all of that makes sense. And it's just an issue that we're having. So that brings me to the next section, but I do want to stop real quick and just ask Ashley if we've had any questions come in the chat, just to see what's going on here.
We have not had any questions come in the chat yet.
Okay, thank you, Ashley. So in this next section, we're going to look at the documentation criteria. In other words, we are going to talk about what the medical review staff is looking for in the documentation to prove medical necessity. With that said, these are, I'll summarize two basic questions for you. There was more provided, obviously, but here's a summary of two questions that we're going to answer during this section. What documentation is needed to prove medical necessity? And what are the documentation requirements? So we'll do those two questions. I'll give you a couple tips, things like that. So hopefully all of this works together to get you the basics for what you really need out of this webinar. So this is the section that if I miss something or you need more information, this is the section where you really need to use that chat. Okay. So the first thing you have to know is that an EMT assessment is the only way to prove medical necessity for an ambulance run. On a claim, somebody asks about the physician certification statement. The Code of Federal Regulations specifically says that the physician certification statement does not alone prove medical necessity. That's why you can get a provisionary decision, and hopefully that makes sense, for yes, we can pay this claim, but it's not the same as having an EMT assessment. So with that said, the EMT assessment must occur for every Medicare billable transport. And remember, Medicare does not, on the Part B side, allow for a round trip. The only time a round trip is allowed for a Medicare is when the patient is inpatient and you are going to bill a facility for the inpatient care. That's not what we're talking about here, okay? So everyone has to stand alone. A great example of that would be to and from dialysis. That's 2 trips because the patient is not inpatient during that time, okay? So what are you looking for when you look at the EMT assessment? First, what is the EMT's medical training that is required? And if there is no medical training required because it's a medical monitoring situation, why do we medically need to monitor this patient for whatever the situation is, whatever the condition is, whatever's happening with the patient? Okay, why do we need to do that? So when I ask my medical review team, hey, what's going on with this? And when I ask the nurses here in the provider arts education area, what are we looking for? The first thing they tell me is that in the assessment, there has to be a patient's on scene complaint. It is great to have something from dispatch. However, that will justify emergent and non-emergent. That does not necessarily justify a medically necessary transport. Now, why is that? How many of you have had an EMT within their medical records documented they were dispatched for a heart attack and they get there, the patient's ready to go and they're like, oh, I don't really have, it's just a chest pain, or, oh no, it's just an anxiety attack. So the on-scene complaint is actually different. Okay. Now, a chest pain and a heart attack, those could be different ones, but we had one where the person said they needed to go in for an immediate surgery. Well, the reality is it was a scheduled surgery. They knew they needed to go. They just didn't have anyone to take them, but they needed to go to the hospital. So they called 911 and reported that they had this medical condition. And when they got there, the EMT noted they were up, they were walking around. They reported that they needed to go for surgery, which was very different than what the patient complaint was during dispatch. So that's why they say the on-scene complaint. Also, when an EMT assesses someone, they need to give us what they see: shapes, sizes, bone tissue, color or lack thereof, anything like that. What do they see? What do they hear? Well, are they having breathing difficulties? They hear the patient stating something or mumbling incoherently. They're not hearing it. They're not getting the full picture. The patient's not coherent. That's also going to be something they can possibly hear. Now, they could also see some of that. One of the ones that gets questioned a lot is smell. What do they smell? And let me give you a couple of examples from our medical review team. One, do you smell alcohol or other drugs? Something that will honestly change the way in which they can comprehend. Do you smell an infection such as gangrene? Do you smell vomit on their breath? All of those are types of things that you would want to document more just to help us understand the full picture. Also, what does the EMT feel? Is something misaligned? Do they have a hard abdomen? Were they in a car accident and there's an internal bleed, or a belief that there's an internal bleed because of that hard abdomen? So what are you actually feeling? And all of those are playing into it. Also, with the EMT assessment, remember that bystander information or family member information can be equally as important. We can consider what you're finding out from someone else. That is key. Why did you do what you did, and what did you know at the time of transport? That's all going to play into the assessment. So I wanted to kind of put that together first. I'll keep going and just talk about a couple of tips. So one of the things that comes up often is that this patient's immobile or this patient is bedridden. Well, why are they immobile? Why are they bedridden? Because just being bedridden alone isn't going to be enough to get that to be payable. Now, if you said they can't stand or pivot without help because or they don't have legs, they're a new amputee who's in a car accident and lost both of their legs, they're not able to even sit in a wheelchair at this point. Okay, that's what we need to know. One of the other ones is positioning requirements. For those of you that are not familiar with this, tell me during the EMT assessment what is going to require them to need to be repositioned. Is there one, a severe pain? Is it preventing contractures? Is there an ulcer or a wound that is located in an area where repositioning will have to occur multiple times in order for the patient comfort or in order for them not to cause further damage? What's going on and why is that repositioning needed? So that is one that we really do like to see in a lot more information. Is there a respiratory or a cardiac need? And especially with respiratory, it's not just that they need documentation. A lot of people live every day with, sorry, not documentation, oxygen. A lot of people live every day with oxygen. They have tubes, they have things. So why do they need the EMT to monitor, adjust, or change that oxygen constantly? Are they having congestive heart failure? Are they having COPD issues? Are they having something that's going to make that happen? Hopefully that makes sense to everyone. Um, we always like to say, hey, is there a special equipment that's needed or something that's happening? You know, maybe it's due to the size of the person and they literally can't stand up. So you're going to have to use a crane to lift them into the bed, anything like that. Okay. Do you have a history of conservative measures that didn't work in the past? Yeah, no. So now we're like, okay, we need to do this to make this happen. And this is just a past history. This is something you know about the patient that we wouldn't know because each claim must stand alone. We being a medical reviewer in Medicare. So keep all of those in mind. Those are just some generalized tips. Okay. I do want to talk just briefly with that on the generalized tips and talk about bed confinement because a lot of people try to use bed confinement and that's the words that they use. But then when the medical review documentation comes in and they're trying to figure out what happens, they're just not getting what they need out of it. And that's what creates a medical necessity issue, which creates a claims issue. So keep in mind, the Code of Federal Regulation, and it's on the bottom down there, it's 42 CFR 420.40 E1, states that bed confinement alone is not a reason for a Medicare to pay a transport. Instead, it's a condition that we would consider. What does that mean? That means during your assessment, you have to be able to find within that documentation where the EMT told you, why is this patient bed confined, first of all? So yes, they're bed confined, but why? What is the body repositioning or the issue that's going on with this patient? Why are they unable to get up from the bed without assistance? And why can't they pivot or turn to get into a wheelchair? Why are they unable to sit? Why in general are they unable to sit? Now, again, it could be a variety of different things. Okay. Why can't they ambulate? What's going on? So please remember that when we're looking for bed confinement, we're looking for so much more than just a generalized statement. And that alone has caused a lot of issues. Again, it's not something WPS is looking for in general. It's something that is being required for us to look at. And that requirement is from the Code of Federal Regulations. The next slide we actually put in is the physician certification statement. And this one we put in due to a huge variety of questions like, does CMS require a certain form for the physician certification statement? Is the physician certification statement required? Do we need it for this type of transport or which type of transport? So we're going to go through a few slides on the physician certification statement to try to answer all the questions regarding this. So, all right. So first, what is a physician certification statement, or a PCS? It is a doctor or medical professional's written opinion on why a transport is medically necessary. The one word missing out of that basic description is it's a written opinion. This does not alone prove medical necessity. It can guide an EMT assessment. Why not? This written opinion can be written up to 60 days before a transport occurs. Medical necessity must be proven for each transport on that day. So can a patient's condition change within 60 days? Absolutely. And that's why it's not alone going to prove it. The PCS is required for non-emergency scheduled repetitive ambulance services, or RASNet, prior authorization, or a service that is just a scheduled non-emergency repetitive ambulance service. Okay. When that comes in for prior authorization, it is the only thing we're considering at that point, and we will give you a provisional affirmation. But again, the actual proof that that occurred or needed to be occurred is still within the EMT assessment. So hopefully that makes sense. And when we say it's required, we are also talking about it being signed by a physician or by a doctor, which can be an MD or DO. If it's a non-emergency or non-scheduled ambulance transport, there is a bit more flexibility, but it does require a documentation. So a non-emergency unscheduled transport, as an example, would be like a one-time transport, and you're going for an MRI. It's still 24 hours or more in advance. It's still scheduled. It's just only going to happen once. An unscheduled transport would be you're going for an MRI, but it was scheduled today and you're going to go later today. So you're going at 8 a.m., but your MRI is at 3. It's still within that 24-hour window, but it's going to occur once. So make sure that you're looking for those different things. And then we do have a bit more flexibility. And we'll talk a little bit more about that. So remember, scheduled transports 24 hours or more in advance. It has to be, repetitive 3 or more times in a 10-day period. All of those different criteria would require a physician to sign. A non-physician could only just sign if it doesn't meet those criteria. And if you want to know all of that, I do recommend looking up the Code of Federal Regulation that we gave you before, or looking at our website for that information. This does not override the EMT assessment on the date of transport. Okay, so it is required, but it's not overridden. Hopefully that all makes sense to everyone. All right. So PSC non-scheduled or non-repetitive. I did want to put this one in, but I put this one in because this is the special rules where the nurse, the PA, all of those people could sign. So we put it in just for that second column where it says nurse, PA, NP. So all of those types of people and who could sign for it. So hopefully that makes sense. This is not the one that has the full criteria. Okay. Now do keep in mind that if the treating physician does sign, that's great. You only need the signature before billing, or you need to have attempted to get the signature. So that's where some of the other criteria come in within 21 calendar days and all of that different stuff. I really will recommend that you do take a look at the Code of Federal Regulations for more information on a PCS, because again, it's not the established, it's not the establishing portion of medical necessity. All right, next we're gonna explore some documentation examples, and you're gonna have me give you a couple things to look at, and then we'll go through each one of the examples a little differently. I will give you a couple of different components, and if there's something missing, I'll try to make sure we get everything within that area. Okay. Before I leave this and get into the actual documentation examples, let me stop for a second and ask Ashley, do we have any questions on the information up till now?
We did have a few questions come into the chat. All right, the first one asks, will Medicare pay for transport to doctor's office for a procedure or to a physician's office in a hospital for a procedure?
So remember, if you're billing the transport code physician office, which is a P, destination, that is not a payable destination. If you're billing hospital, then yes, we would consider that, and that would be an 8. So it depends on what you're putting on there in the origin and destination modifier and where you're actually transporting the patient. If the intent is the physician's office, then that is a never covered transport because it's not something Medicare will cover by destination modifier. Next question.
We had a couple more. The next one is, does contraindicated cover severe weather like an ice storm? Patient didn't meet medical necessity except the was ground ambulance, wheelchair van not available due to winter storm.
No, medical necessity does not do that. That's not a contraindicated transport. What is contraindicated when the patient does need to go by ambulance. So just because it's not available and you use the term weather related, in this case the ice storm, that doesn't make it medically necessary. It doesn't do that. So again, no. What you have to look at is what is the patient's medical need for the EMT's medical skills, which they are required to have training and be licensed for. That's what makes contraindicated, not the availability, not the weather, not anything like that. All of that would not meet that definition. Next.
All right, the last question that came in is, they said, since you said PCS can be written within 60 days, does the date have to match the date of transport?
Oh no. On a PCS, no. Now remember, it has to be within 60 days of the transport, yes, but it doesn't have to match at all, and it can actually come in. Let's say you're doing a one-time transport. Again, let's use MRI as the example. That could just come in. Again, just come in, and it can even be dated after the transport. That's okay because it's a one-time non-scheduled, I'm sorry, one-time scheduled transport, and that meets the definition that way. What it has to be done is certified before you bill Medicare. So yes, it can be done, and you can even do it within 14 days of the transport is very normal. And if you don't have it within 14 days, did you make attempts to get it? If you answer yes, then you could even bill saying, hey. So very situational on that, but no, the date does not have to be on the date of the actual transport. All right. I think you said that was the last question. So if it is, then we'll move on and we'll take more later. Anything else, Ashley?
We just had one more comment, a quick question if you want to take it now, or we can wait.
Go ahead. Go ahead. Sorry.
Okay, the last one, I think, is how does Medicare define round trip?
Medicare defines round trip when a patient must go to a destination and be transported back from that destination. Now, again, a round trip is not part of the Part B benefit package. So in other words, I'm taking them somewhere and back to the other place. Let me give you an example. The patient is in a skilled nursing facility stay. They need to go to a dialysis center during that stay. They're in the stay because they broke their hip and they're trying to recover. And so they're doing PT, which is physical therapy, for that broken hip. That's all normal. The round trip occurs when the inpatient stay, they have to go to the dialysis center and come back. That is a round trip. From the inpatient stay portion, which is go to the skilled nursing facility, that is where Medicare looks at it. Now, Medicare Part B does not consider a round trip. They would actually say that is two separate trips. So that's what we're looking for when we say round trip. Okay. So hopefully I got everything from there, and we'll go ahead and move on. Just for the sake of getting through the documentation examples, I want to make sure we get through everything so everyone has a chance to see this different stuff. All right. So, all right. So in the documentation example, what are you looking for? We'll always start with the basics. Remember, we said, hey, you got to answer these basic questions. Well, also, there's some really basic things within the documentation. Is one, can you identify the patient? Now, a lot of my documentation examples, and anyone, you're going to have a transport demographic portion. you're going to see a lot of stuff blacked out. So I'll tell you if it's available or not and what happened with that. We're also looking for things like, hey, is this a valid destination? Is it coded correctly? Are the signs and symptoms there? Is the signature there? Is this a preference? Because if it's the patient doctor's preference, patient or doctor, I guess it could be a family member as well, that doesn't necessarily make it medically necessary, but it also doesn't mean it's not. It also may affect the coded mileage. So for instance, this is the closest facility or not because of preference. And so there you could code an A0425 for ground with an A0888, meaning, hey, there's some additional mileage that's not payable. Then we also look for what is the EMT skills that are needed. What are the skills? This is your medical training and medical skills, or your monitoring skills as required or trained. So these are the basic things that we're going to try to identify when we look at these different documentation. Okay. So the first one is actually a physician certification statement. This was used from the repetitive scheduled non-emergent ambulance transport ResNet program. So they sent this in to say, hey, we feel like this should get us a prior authorization. Okay. And so that's the only thing they're sending to us, because remember, the transport hasn't occurred. This is for future transports 60 days from this. Okay. So here we go. So transport demographics, do we have the demographics we need? And the answer is yes, we do. Now, unfortunately on this, when you see all these blue boxes and we talked about the redacted information or the information we can't give to you due to PHI, protected health information, or personally identifiable information, that's what all these little boxes are. But I will let you know is we do have all the demographic information. I can tell you the patient, I can tell you their date of birth, I can tell you male and female. I can tell you all the basic information, including the trip dates and for how long, because that's what this 1-9, and this is what ongoing states. Then a little bit more here. Pickup location is the patient's home, and they're taking him to dialysis. So this is a routine scheduled ambulance transport for dialysis. Okay, so we're good on the first part, which is our demographics. Next is the transport reason. Now, a couple of people pointed out during my posting process, just a couple of comments, that it's really hard to read this. I do understand that, but this is literally what we get in. Now, what's really nice with this one is they did use the check boxes, and they being the medical professional that signed it, the doctor's name. Okay, but not only did they do that, they also wrote a big area. So this is really good. It tells us everything we need. Okay. So we're good. Here's what didn't happen with some of the basic information on this one. This one did not get rejected right away. Now, why would it get rejected right away? Well, that's this portion down here, or a demographic missing. We'll talk about that coming up next. And that's because the first thing we have to do is make sure it's valid. So lots going on with this one. We also do want to make sure that we have the doctor's name with medical credentials. That's why I said it didn't get rejected, because we actually do have that. We have their MPI. We have all of these different pieces that we need. Okay, so really like this one. It was really a good documentation example. If you want to read, you can actually read, hey, this is muscle weakness. This is what else is going on. This is all the different things that this patient has. And then why do they have these different items? It's all there. All right. So on slide 21, what is the narrative? Okay, so this is things that we're looking at to make sure that we have some basic pieces of information. This is the next example. Okay, so here we have a narrative. Patient was found seated on the couch, and if you read through this narrative, we're trying to find where it was medically necessary or why the patient could not sign. Now, why is that important? Because on this a little bit later in the patient's chart, there's no signature. The patient signature is missing. So we have to use this narrative to tell us why this patient was unable to sign. Without that portion, we can't have the claim processed. So this one will not make medical review if they cannot find that patient signature. So in the narrative, as we read through it, we're looking for why the patient's unable to sign. All right, so the patient was seated on a couch in the tripod position. They did have oxygen on. They complained of breathing difficulty and chest pains. Vitals obtained, including, reported non-breathing last night that resulted in chest pain worsened with deep inhalation. Okay, so I'm still not seeing anything that the patient can't use their arm, can't sign, can't do any of that, right? This is all about breathing difficulty. Um, so someone asked me, well, does this have to be given at the time of service? Uh, Being given, yes, this can all be done, but does this patient's signature have to be received at the time of service? And the answer is no. You can have them sign before billing, but not necessarily at the time of service. So, okay, we don't see within the narrative why there would be a reason not to sign. What do we do next? Well, then we look at their reason here, and this is from their, again, they're more in their narratives. Okay, we're just looking for what are we missing? Why couldn't they sign? Okay, EMT helped the patient to stand and pivot. Patient was unsteady on feet, but reported they were not feeling sick or dizzy. Patient had acquired. Okay, again, where in this does it state the patient's unable to sign? We don't have that piece of information. And again, we've looked at a couple different pieces within the narrative, right? So then we hit this one and it's like, okay, the patient's present illness. And again, this is a different one where the patient was unable to sign. We have nothing going on here, but we don't really know what happened. So again, here's the next one. And again, it's the missing something. What's it missing? The patient's signature, which means we would not consider these notes. Hopefully that makes sense. It's the basic criteria that we talked about. Remember, we said it has to meet all those basic criteria. These are 3 examples of ones that don't, where the first one was an example of something really good that did. Okay. This is the last one, which just has a really short narrative. And I included it just because it has a really short narrative. It's not, you, it's not a narrative alone, but it does give you some basic information. So normal baseline for the patient, patient's alert and oriented. So it's got just a really short mental self. Here's the assessment, and it's actually blank. That doesn't mean that that alone means we're not going to look at it, because each portion of the assessment would be considered and depending upon what is included with that. And so we get down into some of it and you'll see what's going on with this patient. Okay. Uh, but here you're seeing, pupils, all of the different pieces. So it's incorporated because it has nicely written information versus like a checklist for some of the different stuff. Now, it is how it just presents and the information that presents upon this. Here is the pain rating. So this is important to also make sense. And we want to probably have a better explanation of why this is a pain rating. And then we hit the extremities: bleeding uncontrollably, pain, found a compound fracture, bleeding. This is what makes it medically necessary, where if you notice, there is no written narrative within the assessment. It's just this one portion down here. So I incorporated it again because it's a different form, a different way of doing an assessment, and it's not wrong. It's not right or wrong. It's actually fine. It just gives us what we need, but in a different format. So hopefully that one makes sense to everybody as we go through the different examples. Okay. Let's hit those registration questions, then we'll go back to the chat questions. So the first registration question that I don't think I've really answered is, define the specific skills of an EMT paramedic that contribute to medical necessity. The first thing I want to remind you is that these specific skills are the medical training skills. Your licensure requires medical training. What makes it what makes you licensable as an EMT in your state? That's what Medicare is looking for. So when we talk about, it doesn't matter which level, what makes you licensable in your state? What are the medically trained skills that allow you to be licensed as an EMT? And then how did you use those skills during the transport? Um, We were asked to show different ways to show medical necessity. And again, that's why I put the last chart note in there, because a lot of people think that a narrative is simply a written statement, and it doesn't necessarily have to be. If you saw that, it's a very short narrative in the last example, right? But it was right down there in the bottom, and it was a different format than having a long written statement of all the events and everything that occurred. Instead, it was just a very different format. So I put that in to kind of show that medical necessity can happen in a different way. The next question is NEMT transports. This one kind of threw me off. I'm not really sure what you were looking for with the non-emergent transports and when can they be covered. Yes, we know they can be covered. We just need you to document why it's medically necessary. Why is the only safe means of transport an ambulance? That's what we're looking for. So when we do that, we say, hey, you showed up for an assessment. I get that it's non-emergency transport, understand that. And what's going on with this patient today that makes this the only safe means of transport? Did you do an assessment? During that assessment, what did you find? Is there a medical training or a medical monitoring that needs to occur? Why do you need to do that? So that's kind of the answer for that one. If you need more, please put something back into the chat for that. The next one is very specific, and I talked a little bit about it, but the question is, what if a patient is homeless and just wants to go to the ER to get out of the weather? From this question, from the way that it's worded, we would tell you that it is not medically necessary, because if they just want to go to the ER to get out of the weather, why couldn't they have gone by a taxi? Why couldn't they have gone by a police officer? Now, I'm not saying that those are the appropriate methods or that they could afford to go that way. That's not what Medicare considers. What Medicare considers is, why do they need the ambulance transport? What makes it medically necessary? What makes it the only safe means of transport? And the description given, it's not there. I will also tell you that this person is not from a WPS jurisdiction. So if you want more information, you do need to reach out to your Medicare administrative contractor or MAC to get that. We did get something just saying PCS. I put this one back in because I did build some slides in to hopefully address it, but I want to remind you that if you need more information on the PCS and how that works with ambulance medical necessity for the claim, to ask the question, because the PCS alone does prove the RASNAT or the prior authorization, affirmation or non-affirmation, but it does not prove the medical necessity for a claim. Does not prove the medical necessity for a claim. With that, if you have an approved prior authorization, that means WPS likely will not pull it for a review, but it doesn't mean that another contractor may not, or that another federal entity may not pull. So it's kind of different. And remember that the assessment is what we're looking at there. So that's all the questions that we had from registration that I didn't cover throughout the other portion. So let's check back with Ashley. Do we have any more questions in the chat?
We did get a couple more questions in the chat. The first one says, just to clarify, for treat no transport, you need to use GX modifier.
Oh, it depends. Of course, it's not like an easy, straightforward answer. Here's what it depends upon. GY if you did not give an ABN, GX if you did give an ABN. So you can use either modifier, but it really just depends on whether or not you gave the ABN, the advanced beneficiary notice. Next.
All right, the next one is for the additional mileage you spoke of, you have to obtain an ABN form, correct?
No, the actual Social Security Act, I didn't give you that question, but it does say to the nearest facility. So when we look at that, the additional mileage is not something you have to limit against. So because it's within the I don't know how to say it, but because it's within the section or within the law, it's not an ABN required situation at all. So I'm not sure exactly what you're thinking there, but no ABN required. You're going to bill A055 for the covered portion, and then the additional mileage would be the A0888. No, you don't have to give an ABN because the A0888 states it's beyond the nearest appropriate facility, which is a statutorily excluded portion. Hopefully that makes sense.
All right, your mic was cutting out just a little bit there at the end, Tom, and I got that same comment for the question on round trip. What does Medicare consider round trip? So if you wouldn't mind maybe just touching on that one again, and then other than that, that's all the questions.
Sure, round trip is not applicable for a Part B covered transport. They are one-way trips. Round trip occurs when the patient is in an inpatient Medicare covered Part A stay. My best example is a skilled nursing facility stay, which is medically necessary. Round trip occurs when the patient needs to go to dialysis, right? I mean, the patient literally needs to go to a dialysis center or needs to go for something and they come back. When you bill Medicare as a Part B benefit, yes, it is a round trip, but Medicare requires two separate billings on that. Now, if they needed to go to an MRI, for instance, and they're not going to a hospital, they're going to a freestanding center, this is something that is billed to the skilled nursing facility. Therefore, the to and from for that MRI are billed that way. They are one trip billed to the skilled nursing facility, which is a round trip to and from. So hopefully I didn't cut out too bad on that. Please let me know if I did, Ashley.
No, no, that was much better.
Okay. Anything else?
We have one more come in if we have time to take one more.
Sure, we might as well take it and then we'll finish up.
All right, sounds good. Okay, the last one is, can you talk about a pronounced patient and how that is billed as a treat no transport?
Okay. So a pronounced patient means that one of two things, well, for Medicare purposes, and let me just state this. If they're dead before you know, or before you go, not before you know, obviously, if they're dead before you go, or they're pronounced dead, if they're dead before you go, so if they're pronounced dead, then you do not have a billable transport. That's just non-covered. You don't need to do that. If you are transported, or if you are dispatched, but before transport, let's say you're dispatched expecting someone to have had a heart attack, right? They've had a heart attack. Then you get there and they're dead. This would be billed with a QL, the treat no transport, in that you expected them to be alive. You may not have actually done anything other than arrived, done a quick assessment, and been like, well, they've been dead for 3 days. Okay, you still have a QL. Quit. Some people like to call it the quit living modifier. That does not necessarily have an origin and destination modifier because where did you take them? Instead, you would go with a QL. On the other hand, if you're in the middle of a transport and they pass away and you're like, I don't have anything else to do with them, they're now passed away, then you don't bill that. You bill it with the valid origin and destination modifier of where you were taking them. So it could be a hospital transport and you bill the full mileage with that that hospital destination. That's just my best example for an emergency room. So Ashley, did that one come through loud and clear?
Yes, I was able to hear you for that one.
Perfect. All right, so we're gonna go ahead and move on from there. I want to remind everybody, and I asked Ashley to put this into the chat. There's going to be a survey that you can take for us. The survey helps us and CMS by getting feedback. A couple of different things that we're going to do. One, we're going to put the link in the chat. Go ahead, click it now, take the survey, tell us what you think. Two, we're going to go ahead and close the event and take you to the survey, and that's where the first picture comes up, the top picture. Three, we're going to give you the opportunity to provide feedback and to ask questions. That comes out in the feedback email or the survey email, which is going to come next. So the thanks for attending email. And that'll have a survey link. And last, if you are listening via via our YouTube Encore playlist or via our YouTube website videos, please feel free to look for the picture on the bottom and take a survey there. A lot of different things. Wanted to give you guys just a couple of fast reminders. First, we do have a National Provider Compliance Conference from CMS coming up. It is an in-person conference, and it is in Charlotte, North Carolina. Registration is closed due to the event being full, but the slide is still here because you could sign up for a wait list should an open spot become. So please feel free to look at that if you want to. Our website has a good amount of links on it. We do have a National AB/MAC Ambulance Provider and Supplier Coalition meeting. This is the one that I referenced earlier. For those of you that are interested in this, if you are not from the WPS jurisdiction, this may be a way to get your MAC to answer questions. All of us are involved in it, being all MACs. So this is something just to look at. We are still taking pre-submitted questions, and we'll do that through July 30th, 2026, but you need to submit them to the Medicare administrative contractor that you personally submit your claims to. So hopefully all of that makes sense. You can use the link on the slide, or you can go to our website, type in this coalition, and you'll find the information. A little bit about overpayments. Just as a reminder, if you do get an overpayment, yes, you need to respond. We would encourage you to send the money back or to set up the request via our website on Snap. If you are not doing that and you're using a paper request, we do recommend that you use our request form. It gives us all of the information needed. Also, when you look at the request form, there are 3 fields across the top, so please make sure that you are filling out the correct contract, Medicare type, and state where the service occurred. This will help us get it into the correct batch and not cause other processing issues. That's it, everybody. Thanks for attending. I want to remind you, you can still send me an email with questions, and you're going to email wps.gha.education@wpsic.com. You got 7 days to do that. You can put ambulance webinar in the subject line, and we'll get that back to you. So thank you for listening. And on behalf of myself and Ashley, please remember to comment and take our survey. Also, we look forward to those comments and seeing what you have to say. We hope that you will attend one of our future events. You may now disconnect. Again, thanks everyone.